chat right out of the chat box. What is a supported breath? Supported breath is actually initiated by the patient. Okay, then maybe limited by the ventilator and cycled again by the patient. Assisted breath is initiated by the patient but limited and cycled by the ventilator. Types of ventilators, somebody asked, yeah, there can be different kinds of answers, maybe negative pressure ventilators, which are non-existent these days, positive pressure ventilator, or you can categorize it like ICU ventilators, anesthesia ventilators, transport ventilators, or you can classify like manual bag resuscitator, ambu bag as a manual ventilator and other mechanical ventilators. Okay, so there are different kinds of classification available. It depends on which source the examiner or the person is referring to. Scalars and loops I have already explained. Do we compensate for volume expansion of the circuit attached for adult cases? Not much, because your pre-use checklist itself, the machine will calculate the tube compliance. Even if you ignore it, doesn't matter much as long as you are not ventilating a neonate. What do you, which mode do you think need less sedation, and whether you use relaxant? Our idea is to keep the patient passive. So most of the newer modes we'll discuss, and the sedation requirement we'll be discussing along with that. Regarding relaxants, the present trend is to reduce the use of relaxants to the minimum, and maybe monitor the neuromuscular blockade as and when you start on relaxant. But the lesser the amount of relaxants you use, better it will be for the long-term outcome, because your critical illness neuropathy and other complications and prolonged ventilation issues will be far lesser if you can keep the patient passive by addition of additional opioid or deeper sedation. Head injury or postoperative patient of head operation, PEEP should be zero. Is it true? PEEP actually should be used cautiously in patients who have intracranial anomalies, or when you are speaking about unilateral or focal lung diseases, when the patient is having hypotension, hypovolemia, pulmonary embolism, or dynamic hyperinflation without airflow limitation, or even in the case of bronchopleural fistula. High PEEP might cause venous congestion and raised ICP. It may also have undesirable consequences in patients undergoing prone ventilation, because whichever way high PEEP is going to help you may work the other way when you try for prone ventilation. In modern era, zero PEEP is usually used only for patients in severe bronchospasm, in severe exacerbation, that too when the patient is passive and paralyzed. Otherwise, present day, not many people advocate for zero PEEP. Triggering mechanism in assist control mode. Quick revision, I think there are two kinds of triggers, flow sensor trigger or pressure trigger. There is a continuous flow, delivered flow from the machine, and the machine will check for return flow. When the patient tries to attempt a spontaneous breathing, the return flow reduces. Okay, so to compensate for that, machine will sense and the bias flow gradually increases, and then machine proceeds to give an assisted breath. When it comes to pressure triggering, when the pressure tracing comes down, maybe if you set -2 centimeters of water from the baseline, if it is pulled down to -2, then the next breath is assisted breath is triggered. Usually flow triggering, we usually keep 2 liters per minute for flow trigger. Difference in SAME, pressure controlled and volume controlled by graph, we have already explained. And volume controlled, usually you get square wave pattern flow, usually we get. Okay, I think one of the person asked whether decelerating flow pattern is acceptable in volume control. Yes, some of the manufacturers allow to use a decelerating flow pattern also, but the change is, here in a constant flow, you can have an inspiratory pause and your plateau pressure you can get. In a decelerating flow pattern, it may not be that much reliable. Otherwise, there is not much point in the type of flow pattern. Okay, that's what I understand. Pressure modes, the decelerating flow pattern is usually used. You can see the volume touches the maximum and then waits till the cycling occurs. So this is the typical pressure tracing. Depending on your rise time, the pressure value rises to the set pressure, and then maintains till the cycling occurs. Okay, in volume control mode, I have already explained, can we have flow descending in descending mode? Yes, some of the ventilators will allow to change the flow pattern.